Hello, everyone. Today I'll be presenting immunotherapy, a way forward to improve outcomes in relapsed refractory ALL. I'll be trying to speak the shortcomings or the deficiencies of the data available in the immunotherapy space in ALL relapsed refractory space. So I'm supposed to debate against the motion of immunotherapy. Therefore, I'll be speaking in those lines. So these are my disclaimers. So the data that would be presented would be true to the best of my knowledge. There is a component of debate bias, and it is not meant to hurt anyone. So, if someone is going to debate against the new treatment in ALL, the immunotherapy part, I think it's a lost game, and it's like watching Ramayana again and again. And you know who is the winner and who is the loser. So we all know that immunotherapy has sort of revolutionized the management of ALL. And this is my situation at present. Uh, Everybody is on one side and I am on the other side. So the company is on one side. The doctors have used it and they have got excellent results with these molecules. They're on the other side. And I'm alone standing on the other side. So I can remember one of the old movie scenes just to say in which situation I am in. Well, relapsed refractory ALL is a deadly disease. Stem cell transplant is the most curative option, and you need a good salvage regimen to make the patient eligible for a transplant. So these are the options for salvage: chemo and immuno. Immuno, we have Blin and INO. And let's go into the data directly. Blinatumomab. What is this? It's a BiTE molecule. BiTE it's a bispecific T cell engager. It acts on CD19 and CD3, and it causes lysis, blinatumomab. It's a bispecific T cell engager. If you look into its data, so what does the data say? So the data basically says this is one of the trials in a relapsed refractory ALL. This did include previous patients who underwent an allo transplant, and 35% patients did not include late relapse. 25% patients were sort of third salvage and beyond. And the overall survival was good, 7.4 versus 4 months. And remember, this is a difficult to treat population. With that, the survival has improved and there is good responses too. So the problem is only 24% underwent a transplant, and there was no overall survival in the subset where salvage was third line and beyond. There were higher adverse events, higher discontinuation, cytokine release syndrome, especially in heavy disease burden, continuous IV infusion for 4 weeks. These were the problems with blinatumomab. Again, this is the subgroup analysis saying that in the subgroup, if it is S3, the salvage 3 or above, there is no overall survival benefit. And if you look into the adverse event comparison between the Blin and the chemo group, you can see that discontinuation is higher in the Blin group, 12 versus 8. ACEs were higher, 60 versus 45. And fatal adverse events were also higher. And the cytokine release syndrome was higher. So therefore, it's not easy to handle Blin, chemotherapy does have hematotoxicities, whereas Blin is known for CRS, or the cytokine release syndrome. So therefore, there's a toxic drug to handle and not as easy to be given. You need specialized center for that. So the toxicities are so severe that there are guidelines and recommendations how to handle the Blin-related toxicities. So that's about Blin. So we saw Blin. It was used in heavily treated population. It did give an overall survival benefit. There were good responses, but S3 and beyond, it did not benefit. And it is highly toxic. Coming on to uh, the Innovate, let's have an innovative view of the Innovate trial. It is the registration trial of Inotuzumab Ozogomycin versus uh, standard of care treatment, phase 3 randomized trial, and this is how the trial design looks like. So just look into the inclusion criteria. CD22 positive, ALL, relapsed refractory, 1 or 2 salvage therapy, and then it did include pH positive if it had failed at least one second generation TKI as well. 1:1 randomization, 160 odd patients in each arm. One arm, um, the Inotuzumab Ozogomycin arm received Inotuzumab on 0.8 on day 1, 0.5, and 0.5, like 3 consecutive weeks followed by a week gap. This constitutes 1 cycle. Like that, up to 6 cycles could be given. And the other arm was the standard of care arm that included FLAG, ARASI, or HIDAC. And just focus on the primary endpoint. The primary endpoint was CR, complete response, or complete response with incomplete hematologic recovery, and overall survival. These were the endpoints, and also look into the stratification points. So what did the trial conclude? The trial concluded that Inotuzumab has higher complete response rates. It has higher minimal residual disease rates. It has a longer PFS, longer overall survival, and veno-occlusive disease being a major adverse event. However, in the conclusion, the overall survival was statistically significant was not mentioned and looks like it has been forgotten. Well, if you look into a disease like a relapsed refractory ALL, where the median average time for survival is around 6 months to 12 months, the events would happen really soon, and you will get a overall survival endpoint very easily. There is no need for having surrogate endpoints like complete response, MRD negativity. You know what you need in a patient who is going to die in half year to 1 year. You need to give him a little more life. That's what should be the ideal endpoint. And you should not get lost or distracted with different other endpoints, surrogates, because you will get the event easily in these patients. So just a higher CR, less number of blasts, higher MRD negativity, higher allo transplant, longer PFS, less toxicity. These cannot be accepted as valid endpoints uh, in a relapsed refractory ALL space. So you need to be loud and clear as to what should be the primary endpoint. Overall survival. And in this trial, overall survival was not met. And look at the, so nowhere in the conclusion or abstract, this particular statement is mentioned. What is mentioned is in the discussion, the second primary objective of this trial to show significantly longer overall survival in the INO arm, was not met as per the pre-specified boundary of p-value. So OS not met, negative trial. Let's go into the details of the trial. Let's go into the results. So in the results, what do they say? They say that the complete remission rates are higher. The complete response rate is 80%. And then they go on to say that among the complete responders and the complete remission, MRD negativity is 78%. That means the MRD negativity is 60% aggregate. So instead of saying 60% MRD negative, you tend to use higher numbers just to deceive you by saying that 80% MRD negative. No, the reality is 60% MRD negative and 80% CRs. This is one. Number two, whether you look into the abstract or into the conclusion, there is nowhere mention on that the primary endpoint, overall survival, was not met. So if you look into the conclusions, the median overall survival was 7.7 versus 6.7 with a hazard ratio of 0.77 with a p-value of 0.04. So it's longer, and nowhere it's mentioned that it did not meet the statistical endpoint. And then if you read in between the lines, so if you look the way in the discussion it is mentioned, in only one area where the second primary objective of this trial, the overall survival, you know, uh, with pre-specified boundary was not met. It is mentioned in one. You need to actually read between the lines, and sort of you're concealing the fact that the OS was not met in the trial. And then look into the conclusions. The conclusion says that both PFS and OS were longer in the inotuzumab arm. Conclusion gives you an impression that the primary endpoint was met, but nowhere it is mentioned. So be careful before you conclude on the trial. The trial had primary endpoint of overall survival with a pre-specified p-value, which was not met. Be loud and clear on that. And then there are explanations as to why the overall survival was not better. So they say that the control arm, the standard of care arm, received subsequent therapies like blinatumab, compassionate access inotuzumab, CAR T cell, TKI, and so on. But that's how it should be. The control arm cannot be deprived of standard treatment. You cannot deliberately weaken the control arm by not giving. So we are speaking of a disease where the mortality is going to happen in 6 months to 1 year. If a drug is really effective, it is going to create an overall survival difference, irrespective of the subsequent therapy in the other arm. So I think no crossover is probably not correct, and depriving the control arm from, or the chemotherapy arm from the side effects is not right. From the subsequent therapy is not right. So the overall survival could not be met despite less stem cell transplant in the chemotherapy arm. So that means if you look into an imbalance in the stem cell transplant, so you see this authors notes, regardless of the treatment group, undergoing follow-up stem cell transplant was a significant predictor of overall survival. And then the author goes on to say that the investigator's discretion was undertaken, and we must bear in mind that circumstances outside the trial's control may have come into play because patients are selected for transplant on the basis of factors like age, comorbidities, donor availability, and so on. So, sort of, if you look into the balance of allogenic stem cell transplant, 41% in the INO and only 11% in the chemotherapy arm received stem cell transplant. 4 times more stem cell transplant was done, and by deliberately weakening the comparator arm. So, whereas in the BRIN study, 24% in each arm received stem cell transplant, but here the comparator arm was deliberately weakened, and you can see the CAT1 is being pampered, the other is being ignored. Just like that, somehow more stem cell transplant was done in the INO arm than in the chemotherapy arm. And probably that may be the reason for the numerical difference in overall survival. But in spite of that, there is no statistically significant difference. So in this, this is not a S3 S4 like the salvage 3 or salvage 4. Where you would expect a stem cell transplant so low. Here you would expect at least a stem cell transplant of 25% in each arm. I feel definitely 11% is too less to digest. So this is about the veno-occlusive disease. More inotuzumab you give, more the liver gets injured, the veno-occlusive disease, the sinusoids get obstructed. And you can see the moment you give 2 cycles, it approaches 20%, and the moment you give 3 cycles, it comes up to 23%. So it's quite high. So VOD is sort of very difficult disease to handle. Therefore, we need to be careful by pumping in more inotuzumab. And the moment you're into 4th cycle and beyond, it's above 40%. So VOD is a real matter of concern. So when is the VOD risk higher? Whenever you are having a stem cell transplant as a component of treatment. before, previous history of stem cell transplant, 50% chance of having a VOD. And if you are using a double alkylator in the conditioning regimen, that will increase the risk of VOD. But remember, allo transplant is the most curative option, and just by giving inotuzumab, you're trying to uh, alter or interfere in the most curative treatment in age more than 55. And bilirubin, even if it is equal to upper limit of normal range, it's going to be harmful. So what is basically doing, just like how the Dronacharya asked Ekalavya for the thumb, similarly, inotuzumab is asking your liver for these transient complete responses. Therefore, we need to be very careful before we pump in more and more inotuzumab, and we need to look into which patient am I giving, what is the liver function, what is the age, and was there a history of transplant. Coming on to CD22 expression, overall survival, inotuzumab versus chemotherapy. So 40% patients with BALL have less than 90% CD22. So if you use inotuzumab in this subset, it is detrimental. And that's what is the forest plot showing. If you look into the hazard ratio, the upper limit of hazard ratio is above 2 and even crossing 4. So probably we need to confine our use of inotuzumab in the subset where the CD22 is more than or equal to 90, and do not use in the subset where it is less than 90. So it continues to show a detrimental result in the subset of pH positive subset. The ideal way to go is chemo with a TKI combination, but pH positive, it is detrimental. And number two, if there was a history of transplant, the VOD would increase and it would be really detrimental. And Asian subset somehow, even though it was a good percentage, Asian subset somehow did not uh, benefit. And in these three subsets, we need to be careful. So, would have been interesting if we had a median overall survival value in the chemotherapy arm who underwent allo transplant, and the overall survival difference between chemo and in the subset who had late relapse more than 2 years. This would be interesting to see what is the difference. So, inotuzumab is not effective and may be harmful in these subsets. Previous stem cell transplant, salvage 2 onwards, pH positivity, translocation 411, CD22 less than 90%, age above 55, Asians, if given for more than one cycle, again, VOD is higher, and stem cell transplant with double alkylator, again, these are the subsets where we need to be careful. And the list continues. T-ALL, no data. CNS disease, we do not know whether it works. Pediatric ALL, there is no label. So probably, the dose of inotuzumab is sort of evolving. Initially, it was given in one dose, and then they broke into small doses of 0.8, 0.5. Probably a lesser dose, would be probably the way to go. Instead of going for an MTD, probably a biologically effective dose would be better with inotuzumab. So, inotuzumab does not improve overall survival. At best, it helps in debulking and improving response rates transiently for some time as a bridge to transfer. Otherwise, it's difficult. So, what are the conclusions by the author? In patients with relapsed refractory ALL, inotuzumab was associated with a greater likelihood of CR, and the potential veno-occlusive disease risk factors must be considered, when treatment decisions are being made. So then coming on to the CAR T cell story. So we know CAR T cell, the different types of CAR T are there. And there is good evidence if you use CAR T even in heavily pre-treated, even previous stem cell transplant is done, even in this subset, the MRD negativity is nearly 80%. And there is persistence of these CAR T cells almost up to 1.5 to 2 years. It has durable action. So there are different types of CAR T, CD137 or CD28 co-stimulator. The one with 137 has a longer or a durable response, even without an allo transplant. The overall survival median is of 19 months, even in heavily pretreated patients. These CAR Ts will sustain in the blood for more than 1.5 to 2 years. Therefore, they have durable responses even without an allotransplant. So coming on to the CAR T toxicity, early, it has early but severe toxicity, but it is transient and it can be easily resolved. Single infusion, OPD infusion, 80% grade 3 adverse events. Within 8 weeks, the CRS is up to 50%. And the grade 3-4 CRS is up to 25%, requiring vasopressors, and cephalopathy is seen but no edema, and these are all transient. So if you compare and contrast the monoclonal antibodies versus CAR T, MRD negativity is higher in CAR T, PFS 14 months in CAR T, overall survival is impressive, 19 months versus 7.7. Previous allo transplant is detrimental. If you use INO, whereas it is curative, it is very effective in the setting. And then if you have S2 and beyond, again here it is detrimental, whereas it is very effective. Consolidation with allotransplant is mandatory if you use a monoclonal antibody, whereas with CAR T, you may avoid it. Toxicities are late and permanent, whereas with CAR T, it is early and transient, and the cost is high, multiple expenses at all the times, for chemo, for monoclonal antibody, for stem cell transplant, for defibrotide, you keep needing money. Whereas CAR T is an initial expense for the initial 8 weeks, and then you can be free. So this is other data with chemotherapy, clofarabine, elrabine also have data. pH positive BLL has excellent data with TKI with chemotherapy. DASA hypercivil has shown a CR of 70%. So just quickly going through a case scenario of a 24-year-old male with no siblings having a BL in 2021, no high cytogenetics, post-induction in CR. After 1 year of maintenance, they would relapse. So this patient was exploring HLA or MUD. So which one would you choose? Whether you would choose an inotuzumab for 2 to 3 cycles, get a CR, undergo a MUD, and then face GVHD, VOD, and use MMF, defibrotide, steroids, and so on, where your future becomes dark, or you use an intensive regimen. In the beginning, use CAR T and stay remission-free when without a transplant. So the conclusions are: relapsed refractory ALL is a deadly disease with a short survival. Definitely immunotherapies have improved outcomes, but they have improved CRs, and the overall survival is mainly because of allogenic transplant. There is no definitive overall survival benefit with inotuzumab. VOD is a real matter of concern. We must consider the factors before we offer this drug. And using CAR T in S1 or S2 is an attractive strategy. Even early on, later on there is data, but even positioning it early on is a good way to see. And treatment for these patients needs to be individualized. So with this, I would thank all of you for your patient listening. Thank you.